Now we come to the second case presentation. The history of the patient is as follows. Patient is a 54-year-old woman who complains of a swelling on the left side of the abdomen for the past 1 year. Okay, so the details or the important facts in the history have been highlighted in blue, which will be summarized in the next slide. Now we come to the analysis of the symptoms of the patient. 54-year-old female, swelling on the left side of the abdomen, progressive for 1 year, recently increasing in size, swelling disappears when she lies down, and prominent when she coughed or lifted something heavy. The bloating and distension of the abdomen over the last 1 month, and it's significant that she has got 3 cesarean sections in the early 90s and 2 laparoscopic surgery in the late 90s. So the clinical problem of this patient is a 54-year-old female with multiple laparotomies and progressive swelling left side of the abdomen for a year with bloating and distension. So the possible causes at this stage from the history will be adhesion colic and incisional hernia. Others include pancreatic cyst or tumor, gastric cancer, colonic cancer, or an abdominal aortic aneurysm. Now we come to the questions. Question number 1. Highlight the significant points in the history. Okay, these are the significant points. 54-year-old woman, swelling left side of the abdomen, bloating and distension, swelling increase in size, and this swelling disappears when she lies down. This is very important, and become prominent when she coughed or lifted something heavy. And it's also important that she has got 3 past cesarean sections and 2 laparoscopic surgeries. What is the significance of repeated lower section cesarean section in this patient? Okay, repeated surgery or laparotomies, as in this case cesarean sections, weakens the abdominal wall muscles, thereby predisposes to the development of incisional hernia. What is the most likely cause of the patient's problem based on her history? Most probably she has got incisional hernia with adhesions, bowel adhesions. What are the predisposing factors? Okay, obesity, post-op wound infection, and post-op wound breakdown, technical inadequacies during surgery, poor technique, poor sutures, chronic illness, and trauma to the abdominal wall. Next we come to the examination of this patient. Again, the important signs have been highlighted in blue in this case, which will be summarized in the next slide. Patient is obese, and from the analysis of signs, we notice that the patient is obese. There's a long midline scar, about 8 to 10 centimeters, from suprapubic right until the umbilicus. Abdomen was slightly full. There's a mass 6 by 6 centimeters at the left periumbilical region. Cough impulse was positive. There is a non-pulsatile, reducible, soft and non-centered swelling, partly reducible, slightly tender, and a gap is palpable in the upper rectal sheath. So the clinical problem from after the examination is a laparotomy scar with a mass, reducible, and slight tenderness, and there's a gap felt in the rectal sheath. So the possible diagnosis in this case will be an incisional hernia with adhesion colic and bowel obstruction as probable causes. However, Pancreatic cyst or a tumor cannot be still ruled out. Now we come to the questions after the examination. What are the significant signs in this patient? Okay, this has already been mentioned. Abdominal scar, abdomen slightly full, mass, left paraumbilical area, positive copy pulse, partly reducible and slightly tender, and a gap felt in the rectus sheath. What is this palpable gap in the midline scar and what is the cause? It is a defect in the rectus sheath due to breakdown after the previous operations. What is the definitive treatment for the patient? Surgical repair is a direct repair, keel repair or Mayo's repair, and nowadays more commonly is the mesh repair. This is important. The procedures can be done either open or through the laparoscopy. There's also a place for conservative treatment to reduce weight, exercises to strengthen the abdominal muscles, and the wearing of supportive abdominal belt. Now we come to some general questions on incisional hernia. What are the differential diagnoses of a mass in the abdomen left of the umbilicus? Okay, this is abdomen here. There's a mass, large midline scar, pushing the umbilicus slightly to the opposite side, to the right side, and then there's a mass here. Large mass with some skin discoloration over it, measuring maybe about 4 by 5 centimeters in diameter. The differential diagnosis will be an incisional hernia, abdominal aortic aneurysm, pancreatic cyst or tumor, colonic carcinoma, or a mesenteric cyst. What imaging investigations would you ask for in such a patient? Okay, commonly abdominal X-ray, ultrasound, and CT scan. If necessary, we can proceed on to do an endoscopy, such as an upper endoscopy or a colonoscopy, and barium wheel studies if necessary. Question number 3. The following is an ultrasound image of a woman with a large paraumbilical swelling. What is your diagnosis? Okay, this is an ultrasound picture. It shows this is a rectus sheath. There is a gap or defect in the rectus sheath, and there's some herniation of bowel from the abdominal cavity into the extraperitoneal space here. With this air-filled loops of bowel here. So this is an ventral incisional hernia. What are the complications of this hernia? Adhesion colic, intestinal obstruction leading to strangulation, gangrene, and even perforation of the bowel with peritonitis and septicemia. These are very serious complications of strangulated incisional hernias. The clinical signs of these complications are pain, abdominal distension, vomiting, constipation, no stools or flatus spas, severe tenderness all over, especially localized tenderness over the area of strangulation, increased bowel sounds in the early stages, and later when peritonitis sets in, the bowel sounds will be absent. And finally, if the patient goes into septicemic shock, which is a very serious complication with high mortality. Question number 5. What advice will you give the patient after the surgical repair? Okay, these are the 5 areas you should look into. Patient's nutritional support. Make sure the patient gets enough nutrition, adequate balanced nutrition to build up to heal the wound. Early mobilization to prevent complications, especially in obese patients, complications of deep vein thrombosis. Abdominal support is very important. These things can be bought commercially in the pharmacies. Avoiding of lifting heavy objects is very important, especially for a period of 6 months after this operation in this patient. And reduce weight if obese. This patient is slightly obese and strongly should advise her to reduce weight and exercises to strengthen the abdominal muscles. The surgery involves is direct repair, keel repair, Mayo's repair, which is called double breasting or overlay repair, mesh repair, which can be overlay or underlay mesh repair, and there's also must be prepared at surgery to proceed with release of adhesions, even resection of the bowel if there is evidence of strangulation. Okay, this slide shows you the types of treatment. Conservative treatment for incisional hernia, when the neck of the hernia is wide and the hernia is small, so the strangulation risk is very small. And when there are no or minimal symptoms, then this patient should be treated conservatively, encourage exercise, diet, and also to strengthening exercises and the wearing of an abdominal belt. Surgery is indicated when the risk for strangulation is high, as in case of large hernias with narrow neck, rapidly increasing size of the hernia, and signs of obstruction and strangulation. The mesh repair is the most commonly done these days. Okay, putting a mesh below the rectal sheath here. This is the rectal sheath. Cover the defect here. Okay, or there are number of times there's the Mayo's operation where it's a double breasting of the rectal sheath, and mesh repair, which can be above or below, overlay or underlay. Okay, mesh repair, sublay or underlay or overlay. Okay, this is the mesh here. This is the overlay mesh. This is the sublay or underlay mesh here. Basically, this is a hernia. Okay, the loop of hernia bowel comes trapped into the sac here, so this has to be reduced, and then a mesh placed and the wound closed. Okay, these are incisional hernias. There is some evidence of strangulation, which is not so good. Here the skin is not so nice. Probably here is okay. If it is reducible, you can treat symptomatically if the patient refuses, until the patient is not responding to your treatment. Here we come to the end of today's topic. Thank you so much for your patience and support.